So, ladies and gentlemen, it is my great pleasure to introduce Dr. Katie Goldie, and her talk is The Gift of a Better Death.
There was a time when dying people and their families didn't openly talk about dying. It was done in discreet ways. In my family, my grandma passed her wedding rings to my mom for safekeeping before she died of lung cancer. Before I dig deeper, I'm going to warn you, I'm here to tell you my story of loss and the feeling of helplessness that came along with navigating the healthcare system with a dying person. I'm confident that many people in this audience have had similar experiences and continue to carry the invisible weight of their own personal losses. Grieving is a deeply human experience. What's noteworthy is the impact that my story had on me, as it motivated me to become a registered nurse and health researcher for the goal of making death a better experience for other people. I'd like to tell you about my grandma. Her name was Lois. We were cut from the same cloth, just 63 years apart, with similar auburn hair, personalities, a sense of humor, and an unspoken language that could be communicated with a single glance. We were kindred spirits. I spent a lot of my childhood with my grandma. I'll never forget the day that I overcame my fear of driving a go-kart at a children's amusement park. My older brother was teasing me for being scared to drive on my own. Watching this, Lois grabbed my hand and dragged me to a double-seated cart before hopping in the driver's seat. You haven't seen love until you see a woman in her 70s elbowing 12-year-old boys off a miniature freeway. My grandma was generous with her time. Her proudest accomplishment outside of her family was the 25 years she spent volunteering at our local hospital. I'd like to tell you more about her vibrant life, big personality, and quiet strengths that kept our family glued together. But instead, I'm going to focus on her death. It left me with the uneasy feeling that the healthcare services she received caused her more harm than good. It's okay to talk about death. I know it's a taboo subject in our death-phobic society. Many people avoid the topic because thinking about anything but a cure for illness can feel like giving up. This is surprising because we know with certainty we will all die, every single one of us. And 90% of Canadians who are dying die from commonly occurring life-limiting illnesses like cancer and heart disease. We know these illnesses shorten life, but it's uncomfortable to think about what they're going to look like in their advanced stages. It's time to start talking about death and dying. Let's start right now. Lois was 80 years old when she died from metastatic lung cancer, which is the most frequently diagnosed and leading cause of cancer death. She was told her cancer was incurable 6 months before she died. She had lots of symptoms like pain and coughing, which made her feel short of breath. There were many days that she didn't want to get off the couch or eat, and there was a palpable tension between my grandparents that wasn't there in their 52 years of marriage. She wasn't acting like herself. They were scared, and my grandfather was struggling to take care of her on his own. This was a different era in healthcare. The father of palliative care, Balford Mont, who's also a Queen's graduate, had introduced the term in 1974, but it hadn't become mainstream, and it definitely wasn't available in our small community hospital. It was assumed that the more interventions in pursuit of a cure, the better, regardless of stage of illness or prognosis. Seeking a cure at all costs was the focus of care, even at the costs of lots of tests, lost time spent in waiting rooms, and side effects of treatments. Because of this approach, my grandmother got cancer treatment right up into the last month of her life. In the end, She developed an infection. She went into an emergency department and quickly deteriorated until her death in an intensive care unit. Modern day healthcare providers refer to this as aggressive end-of-life care. I have hazy memories from the evening that she died. It was cold, it was November. I remember walking into this bright, sterile feeling intensive care unit, hearing a symphony of beeps from various machines, and seeing a crowd of healthcare providers huddled around my grandmother trying to resuscitate her, and speaking urgent medical jargon that I didn't understand. Even with all their effort, it looked like she had already died. I had obviously arrived at a bad time. I was abruptly redirected to this drab, windowless waiting room where I found my father and my grandpa sitting quietly. It was a scene that was opposite to the home-like environment which we'd spent so much time together in. A doctor came out and told us that she had died without ever using the words death or dying. It was shocking and confusing, and we had to keep on asking him what he was trying to tell us before it sank in. Afterward, a very memorable registered nurse named Jackie literally picked us up off the floor, brought us to my grandmother's bedside, and tearfully bared witness to our loss. Losing my grandma blindsided me, although it shouldn't have. Her death was foreseeable, and I'm sure anticipated by her healthcare team. I knew she had cancer, but wasn't told that she was going to die. I was unprepared because I didn't have the important conversations about death that should have taken place. I didn't have the maturity to talk about death with her, ask her about her own wishes for her care, and more importantly, provide her with the space to say goodbye. I promise you this is not just a sad story. 6 years later, I came full circle and had the privilege of becoming a registered nurse and providing care to patients and their families who were hospitalized in an intensive care unit. I was given the opportunity to learn from expert nurses. It was during this time that I noticed that end-of-life care approaches had evolved alongside of the discipline of palliative care. You might think that palliative care is only for cancer patients, only offered at the end of life, and only when treatments have been unsuccessful or stopped. All of this is untrue. Palliative care is in desperate need of a rebranding. End-of-life care is part of palliative care, but it has a much broader scope. It's focused on pain and symptom management, delivered collaboratively by a variety of types of healthcare providers, and can be given at any time during an illness, from diagnosis to death or survivorship, and at the same time as treatment. If you go into a hospital today, there's no wall dividing getting cancer treatment and seeing a palliative care provider. They're not mutually exclusive. Patients can walk 2 roads at the same time. Palliative care is not focused on a single organ system, like many other medical specialties, like cardiology or respirology. Instead, it's devoted entirely to preventing and relieving health-related suffering for people with advanced illness. And not just in cancer, but in non-cancer illnesses as well. Herein lies the paradox of palliative care. People think that palliative care is the same as end-of-life care and will give up and lose hope if it's brought up as an option. This is not the case. Palliative care increases quality of life and in some cases length of life. Let me say that again. People who get palliative care will live better with their illness for longer. Palliative care doesn't shorten life, and it doesn't mean that a patient needs to stop focusing on living. Far from losing hope, people who get palliative care often have better mental health because their symptoms are well controlled and they've had the hard conversations, weighing treatment options with risks and benefits. And they're regularly encouraged to revisit their priorities for care. So what's a good death? I often wonder how my grandmother's death would have looked different if she'd received modern day palliative care. Would it have felt as tragic to me? I like to imagine an alternate scenario where she died in a peaceful environment. Her symptoms were well controlled, she was comfortable, and she was surrounded by family, especially her daughter. It would not have involved so much time spent in hospital, an intensive care unit stay, or aggressive attempts at restarting her heart after she'd died. She could have avoided the emergency department with healthcare provided at home, and this would have lessened the tension between my grandparents and made their time together more meaningful. A healthcare provider could have prepared us by talking about what the dying process was going to look like, instead of protected us by leaving us in the dark. We could have shared our sadness, comforted one another, and talked about how best to honor her legacy with her there. After finishing my PhD in nursing, I decided this is where I want to focus my research. In my role as an assistant professor in the Queen's School of Nursing, I measure the performance of how end-of-life care is delivered across healthcare organizations and measure the impact of providing palliative care earlier, ideally near the diagnosis of advanced illness. I consider a good death as one where patients get early palliative care and supportive end-of-life care. Supportive care means having a healthcare provider coming to a patient's home to treat them. This allows them to be more responsive to patient needs, increases satisfaction, and decreases hospital use. Canadians need universal and equitable access to high-quality palliative care. Currently, fewer than 50% of dying Canadians get palliative care in the last month of their life. That would be equivalent to less than half of the room getting palliative care when they need it. Timely access is needed at all entry points to the healthcare system, and this can be achieved with 4 approaches. Number 1, let's remove the stigma surrounding palliative care by talking about its benefits. Number 2, there are workforce shortages in nursing, medicine, social work, and spiritual care that need to be urgently addressed to make sure that we have enough providers to care for our communities. Number 3, we must explore new models of delivering palliative care, such as using virtual visits or expanding the scope of practice of all types of healthcare providers, especially where palliative care physicians and nurse practitioners are limited. And number 4, more research is needed. We have a lot of good clinical data, but it's overwhelming our ability to analyze it in a meaningful way in real time. It's my dream to use powerful new computing tech tools to gain insights into emerging practice patterns as they happen so that we can continuously improve care. Nursing is indispensable to the delivery of high-quality palliative care. Creativity is needed to optimize nursing roles in clinical practice, especially in underserved communities. In my academic role, I have the privilege of training the next generation of undergraduate nurses and mentoring graduate students to conduct timely and rigorous palliative research. My graduate students are incredible. They work tirelessly as frontline healthcare providers, regularly saving lives and being present with death. They use their voice to speak up about healthcare issues that are important to them, and their discoveries are changing practice. This is modern nursing. Maya Angelou said, "There's no greater agony than an untold story." I've kept this story to myself for more than 2 decades. Telling it has been freeing, as it's prompted conversations to happen in my family that never took place. I hope my grandma's story will serve as a catalyst for you and your family to have similar conversations. And more importantly, consider a fresh perspective on palliative care.